what is HIV and what is AIDS? Well, let's first look at HIV. HIV is a virus that attacks our immune system, and if we expand this out, we can see that that's reflected in its name, human immunodeficiency virus. So this implies that it does something to our immune system somehow, and we'll actually explore that a little bit later on. And if we don't treat HIV, it'll eventually cause AIDS in the infected person, acquired immune deficiency syndrome. So right away, you already get a sense that HIV attacks your immune system so destructively that you end up acquiring an immune deficiency syndrome. It puts you into a state of immune system failure, so you end up not being able to fight off even the most basic infections. And this immuneless state is what we call AIDS. So let's explore this a little bit further now. Let's actually use the help of a graph. This might be helpful. So here's our graph, and we'll put time down here on our x-axis. And actually, just to make this extra useful, we'll put weeks in this beginning part here, and then we'll transition to years here. And you'll see how this is relevant in a few moments here. So on the y-axis here, we'll put CD4 T lymphocyte count. T lymphocytes are a really, really important type of immune system cell, and CD4 just refers to a type of protein that's stuck through their cell membranes. That's kind of how we like to identify them, by this protein on their membranes. And the reason they get a special spot on an entire axis of our graph here is because they're super important in the progression from HIV infection to AIDS. Because, as you might have suspected, it turns out that HIV preferentially loves to infect these CD4 cells of our immune system. And why is this so bad? Well, these CD4 cells, also called helper T cells, play a huge role in signaling your other immune cells to come and destroy any given infectious particle that our body discovers, like maybe strep throat bacteria or flu viruses or even HIV viruses for that matter. So these CD4 cells are kind of central. They're almost like little amplifiers of our immune system. So because HIV loves to infect and kill these cells, it completely disrupts how our immune systems function and renders it essentially useless. So let's say you acquire HIV in your body, either in your bloodstream or your tissues, maybe through unprotected sex with an infected partner. That would be the most common method of becoming infected with HIV in adults at least. What happens? Well, the main thing is that the virus really quickly gets into your white blood cells, so these T helper cells, the CD4 cells we talked about, but also some other white blood cells like your macrophages and so on. And from inside a white blood cell, it can do two things. One, it can sort of hijack your cell's machinery, so it manages to insert its genetic material into your own cell's DNA, and from there it starts to make lots and lots and lots of copies of itself, lots of new HIV particles. Actually, that's really, really important. So let's put that on our graph too. Let's say viral load here on another y-axis here. Viral load referring to the amount of HIV in your bloodstream. So we can see that after our primary infection here, the viral load starts to increase. It's hijacked our T helper cells, and now new HIV particles are being churned out, and our viral load is majorly on the upswing. And you'll notice that the viral load is starting to rise at around the 2 to 3 week mark, and that's just because it takes a bit of time for the HIV virus production to start sort of ramping up within our bodies. And of course, a major concern here is, well, the more HIV there is in your bloodstream, the more CD4 cells get infected, get hijacked, right? But the biggest problem here, thing number 2 here, is that HIV infection of your CD4 cells triggers a self-destruct sequence within these cells. So you end up losing these CD4 cells. And even worse, the self-destruct sequence doesn't just destroy the infected cells. It even destroys nearby immune cells that maybe have come into the area to try to help out. So I won't go into the mechanism in this video, but you do end up losing lots more immune cells than just the infected ones. And that's part of why you see this massive drop-off here. This line representing our CD4 T cell numbers has this really steep downward slope. We're losing lots of T cells, while at the same time our HIV viral load is going up and causing more and more infection of our cells. The other thing I want to point out here is you can see this massive rise in viral load and this pretty massive drop in CD4 levels. And this huge viral load means that this time period, right, early on in an infection is when someone with HIV has the highest risk of transmitting it to someone else. I guess one good thing here is that eventually, maybe a month or so in, your immune system gets somewhat of a handle on the virus, and it starts to make anti-HIV antibodies, right? Those are just antibodies against HIV. So they start to fight off the virus to some extent, and this is called seroconversion, when you make antibodies to something. So now we've seroconverted to HIV. So now the antibodies get to work on helping to destroy the viral particles. And that's why we see this decrease here in viral load in the bloodstream, because our immune system is starting to control the viral levels to some degree. And this also gives our CD4 cells a chance to recover to some extent, because there's less virus around to infect them. So you might be wondering how you're going to feel during all of this, with this massive battle going on inside your body. Well, you're going to feel sick. You're probably going to feel like you're having the worst flu you've ever had. So about a month or so in at seroconversion, you start to fight the infection. And as a result, most people get some serious flu-like symptoms. So things like headache and fever and sore throat, muscle pains, joint pains. Some people get swollen glands, just sort of fatigue and feeling unwell. Some people get a rash. Some people get some open sores in their mouth. These are some of the more common symptoms of an acute infection with HIV. And this flu-like illness that people experience is referred to as acute HIV syndrome. And the reason for a lot of these symptoms is because, well, when immune system cells get really active, or when they die off, both of which are happening here, of course, they tend to release these little chemical signals that cause inflammation, sort of all throughout your body. And so this is what underlies a lot of these symptoms here. So back to our graph, the immune system can't completely kill off the HIV, even though we have antibodies now, right? And that's because remember the rate of immune system killing is roughly matching up with the rate of new viral particles being produced. And B, because the virus has sort of taken up residence in some really, really hard to reach reservoirs within our body, like within the brain and within our bone marrow and within our genital tract. Because of these two reasons, these curves tend to sort of stabilize at some point. They reach a set point where, again, our immune system is killing off HIV at a pretty similar rate to which HIV is replicating. So the curves start to come together a bit more and stabilize somewhat. So this period here is thought of as the start of the second phase of HIV infection, what's called the latency period, or chronic HIV. This acute infection back here being phase 1. So in this latency period, we don't tend to see any clinical signs of HIV illness. The person is often asymptomatic. They're still infectious, but there are few or no symptoms during this phase. And without treatment, this phase will last on average about 10 years. And I said that our curves here stabilized, right? But it turns out that HIV is actually replicating and killing our immune cells just a teensy little bit more than our CD4s are recovering. So over this long period of time, phase 2, eventually, again, without treatment, HIV will start to overwhelm our immune system, and we'll start to see symptoms again. So things like fever or muscle pains or swollen glands, really similar to the acute infection, and again, much for the same reasons as before. And many people at this stage of the illness experience significant weight loss. HIV causes you to use more energy than usual, and also prevents you from absorbing nutrients from your food as well as you normally would. So we often see some significant weight loss for these and a few other reasons as well. Eventually, if our CD4 cells get to a critically low number and results in our having no functional immune system, that's what AIDS is. Essentially a state of being where we have no immune system. So at this point, this is when certain bugs, bacteria and viruses that would never stand a chance against even a minimally effective immune system, these things start to infect the person. And we refer to these specific infections as AIDS-defining illnesses because we just know that if somebody has one of these illnesses, they just cannot have a functioning immune system. It just wouldn't happen. Or at least it would be really, really unusual. So there's a high suspicion of this person having AIDS and not just an HIV infection anymore if they have any of these AIDS-defining illnesses. Two examples of AIDS-defining illnesses are two fungal pneumonias, one called pneumocystis pneumonia and one called cryptococcal pneumonia. These are two common AIDS-defining illnesses. And again, these aren't the types of infections that you get when your immune system works even a little bit. So actually one of two criteria have to be met before we can say someone has AIDS. Either they have to have extremely low amounts of CD4 cells in their blood, and to get a little bit technical here, it's if they have less than 200 CD4 cells per microliter of blood. With the normal count, the normal CD4 count in this amount of blood, it should be around 1,000 to 1,100 CD4 cells. Or, regardless of CD4 count, if they have any of the AIDS-defining illnesses, like either of these, for example, then we can say that they have developed AIDS. And so you might have suspected this, but it's actually the overwhelming impact and the complications of serious infections that you pick up because of the immune deficiency in AIDS that actually results in the death of the person. So from HIV infection to eventually an incredibly high amount of viral particles and a low amount of CD4 cells in the bloodstream to development of a completely non-functional immune system in AIDS, very quickly leading to overwhelming infection by essentially every infectious pathogen from A to Z. And because of this, death results. So we know that an untreated HIV infection destroys your immune system and leads to essentially an immuneless state that we call AIDS, acquired immune deficiency syndrome. So how do we know when an HIV infection isn't just HIV anymore? How do we know it's progressed to AIDS? Well, in one or both of two ways. So here's a graph I'll use to explain. So here's CD4 T cell count on this y-axis. And here's a little timeline. And we'll say that 10 years is about here, because in an untreated HIV infection, it takes about 10 years before your immune system is completely destroyed and AIDS is developed. So when your CD4 cell count has dropped from its normal levels, right, of about 1,200 or so CD4 cells per cubic millimeter of blood, to less than or equal to about 200 cells per cubic millimeter of blood, you've developed AIDS. That's one of two ways to tell. The other possible way to know if you've developed AIDS is if you have any of what are called the AIDS-defining opportunistic infections, which are sicknesses that can only take hold in your body if you have a failing immune system. So regardless of your CD4 count, if you have any of these opportunistic infections, and of course an HIV infection as well, you will be diagnosed with AIDS. So let's do some drawing here to look at what types of AIDS-defining illnesses can come on and when they might come on, because it's important to be on the lookout for signs and symptoms of these conditions, because they can be really dangerous to your health. So generally speaking, people with CD4 counts greater than 500 cells per cubic millimeter of blood are not at risk for opportunistic infections. But, if you're hovering right around 500-ish, then sort of the daily ebb and flow in your CD4 counts means that you might develop some minor infections like thrush in your mouth or yeast infections in the vagina. So thrush symptoms to look out for would be white patches on the gums or on the tongue. And you might also get some pain in the mouth or in the throat, and that would cause some trouble swallowing. And yeast infection symptoms might include vaginal irritation or itching, and also a thick white discharge. And I should probably clarify, so all of these ranges that we're looking at, these aren't set in stone. So you could get certain opportunistic infections at slightly higher T cell counts or CD4 cell counts or slightly lower CD4 T cell counts. These aren't sort of fixed numbers. These are just sort of ranges. Good. So if your CD4 levels continue to drop, you could develop something called Kaposi's sarcoma, which is a tumor or a set of tumors caused by human herpes virus 8, which can only really infect a person with a weakened immune system. So the classic signs that you should look out for with Kaposi sarcoma are these purple patches or nodules, growths almost, that appear usually in the mouth, on the gums, or on your skin. If your CD4 count drops even further to between 100 and 200 cells per cubic millimeter of blood, then you might develop some of the more severe opportunistic infections. For example, Pneumocystis jirovecii pneumonia, also known as Pneumocystis carinii pneumonia, or PCP. So this is a fungal infection of the lungs, and it causes a really, really severe chest infection. And in fact, this is most often the cause of death for someone with AIDS. Two other common fungal infections that might take hold are histoplasmosis and coccidioidomycosis. That's a bit of a mouthful, coccidioidomycosis. And these two are pretty severe because they infect many different parts of your body, not just your lungs. So you can look out for a PCP infection because it presents kind of like a chest infection. So you'd have shortness of breath, you'd have a cough, you'd have chest pain, and, at this point your immune system would still be able to mount a fever, so you'd have a fever. And these two fungal infections present in a similar way, right? Histo and coccidioido. But remember I said that they're systemic diseases, so these can also cause some weight loss and, just general fatigue. Those are systemic symptoms. Now, if your CD4 levels continue to fall to between 50 to 100 cells per cubic millimeter, you can start to develop opportunistic infections that affect your brain, such as toxoplasmosis and cryptococcosis. So toxoplasmosis is caused by a parasite, and it can cause encephalitis, which is swelling of the brain. And because of this swelling of the brain, or encephalitis, a person might develop neurological symptoms like a headache or weakness of their muscles or seizures. These are all signs of a sick brain. And cryptococcosis is yet another fungal infection, and this one usually starts as an infection in your lungs, and then it sort of moves up to your brain and causes cryptococcal meningitis, which can rapidly be fatal. So symptoms of cryptococcal meningitis would be sort of the classic meningitic symptoms, things like a headache and neck stiffness and a fever. And while we're in this little bracket here, two other organisms that can cause serious infections, right, between this 50 to 100 bracket are cryptosporidiosis and CMV, cytomegalovirus. So cryptosporidiosis causes severe gastrointestinal symptoms. So you'd get this chronic, long-standing watery diarrhea because your intestines just aren't absorbing food or water properly. You would get serious stomach cramps, and you'd have severe weight loss. And CMV here, actually CMV is present in most adults, but it only really starts to cause trouble if something's wrong with your immune system. So in someone with really low CD4 levels, CMV can cause problems in the digestive system as well. So the last one I'll talk about happens if your CD4 cell count is less than 50 cells per cubic millimeter of blood. And this one's called Mycobacterium avium complex, or MAC. And this bacteria, sort of similar to all the other bacteria and viruses and fungi that I've talked about so far, they're all present in many different places. Soil, water, on trees, really many places in the environment. But again, they don't cause any problems in people with healthy immune systems. We just fight them off. But MAC in a severely immunocompromised person, like someone with AIDS, can cause a really, really serious infection that spreads through the bloodstream to many other parts of the body. And that'll result in things like high fevers, night sweats, diarrhea, all sorts of systemic symptoms. And MAC can be rapidly fatal as well. Now, everything I've talked about, all of these AIDS-defining opportunistic infections, they can be treated with the right medications. So with access to treatment, they don't have to be life-threatening. You just have to get medical help right away. And then once they're treated, the focus would then be on raising your CD4 cell count with ARV treatment, like HAART, so that hopefully your immune system gets stronger and none of these develop again. How does HIV actually infect our cells? Like, what exactly happens when you get an HIV infection? Well, to find out, let's follow a little HIV particle, an actual virus, through what it does and where it goes in order to infect a human. So let's start by drawing some skin here. Actually, let's say this is mucous membrane, so those soft, moist areas, not quite protected like everywhere else on your body that's covered by normal skin. So you'd find these mucous membranes inside your mouth or in your throat or your nose or inside the vagina or at the tip of the penis or in the rectum or anywhere in your digestive tract, really. Any and all of these are mucous membranes. And remember, this is relevant because the most common way HIV is spread is by sexual contact, which is when these areas or some of these areas are likely to come into contact with infected sexual fluids from each other. And just to jog your memory, remember the second most common way HIV is spread is when it's directly put into your blood from an unsafe needle or from blood-to-blood contact with an HIV-infected person. And, we can sort of intuitively see how HIV can attack our white blood cells, like our CD4 T helper cells or our macrophages, when it's directly put in the bloodstream. That bit's a little obvious. But what's less obvious is how HIV gets into our bodies across our mucous membranes, right? I mean, they look like barriers to me. Well, it turns out that we have these really interesting little immune system cells embedded within and throughout our mucous membranes. And these are called our dendritic cells. And these cells are really quite key in HIV infection. What they do is they protrude their little limbs essentially up to the surface of our mucous membranes because their job is to sort of sample the environment to look for bacteria or viruses or any other threats to our health. And practically speaking, what they do is they sort of continually grab onto particles that they find sitting on top of our membranes here, and they pull them in across the membrane to check them out to see whether they found a good reason to activate our immune system or not, right? They actually have the ability to kick off a pretty big immune reaction depending on what kind of particle they've found. And so what they do in a normal scenario is that if they find something they're worried about, maybe a virus or a bacteria or something like that, they internalize it, and then they kind of cut it up into a few pieces, and then they display little pieces of it, which at this point are called antigens, on their surface, because essentially they want to get other immune cells' attention. They're essentially saying, hey guys, look what I found! Let's make some immune cells that are targeted to these little pieces here, let's wipe this thing out! And really, really, really importantly, while they're doing all this breakdown and displaying of foreign invader antigens, they're also on the move. They've sort of picked up shop and they're already on their way through the bloodstream or through the lymphatic system on their way to one of our many lymph nodes. They usually go to the closest one. Lymph nodes, by the way, are a really important part of our immune system where a lot of our immune cells, particularly our lymphocytes, hang out and sort of filter through our body fluid for any pathogens that they might need to become sensitized to and respond to. You can think of these lymph nodes as police stations where a lot of our cops hang out waiting to be briefed on their next task, to be shown wanted posters, so to speak. This is standard practice for our dendritic cells, by the way. The normal sort of everyday life for these guys goes something like they hang out in the mucosal surface, they find pathogens, they carry them to the lymph nodes to alert the lymphocytes. This is just a normal day for them at this point. The problem with HIV, though, is that it's not quite like the other pathogens, either bacteria or viruses. I mean, some of it gets degraded, right, chopped up and displayed to the lymphocytes in the lymph node here, sure. But some of the HIV actually gets transmitted to the lymph node intact, which is no good. And I'll tell you how that happens. There's three sort of main ways that our dendritic cells sort of misguidedly bring intact HIV to our lymph nodes. One way is by what's called an infectious synapse, where the dendritic cell essentially grabs onto HIV particles using its plasma membrane and then a protein on its plasma membrane, and it essentially carries it, just like this, to the lymph node, and then it sort of hands off the little HIV particle to a T cell to deal with, which usually results in that T cell becoming infected. Another way is where the dendritic cell endocytoses a group of HIV particles, brings that endocytosed group to the lymph node, and then exocytoses them right inside the lymph node where all the other immune cells get exposed to them and can thus get infected as well, right? Not very thoughtful of the dendritic cell to do that. And the third way is that HIV will directly infect our dendritic cell at some point during initial contact either at the mucous membrane or during the period of time when the dendritic cell is traveling to the lymph node. And throwing an infected dendritic cell into a lymph node is generally a terrible idea, probably the worst idea anyone could ever have, because after becoming infected, the dendritic cell will start pumping out copy after copy after copy of HIV particles that are just as infectious as the first one. But you might be wondering, well, how does infection of an immune cell by HIV result in more copies of HIV being made? And that's a great question, and that's actually the standard way that viruses work. They sort of hijack our cellular machinery, and they use it to create lots and lots of copies of themselves that can then sort of leave the infected cell and go on to infect more of our other cells, to sort of repeat the whole process. HIV, though, it sets itself apart from almost every other virus because the way it does this hijacking is a little more different and a lot more sneaky than other viruses. And I'll cover how it hijacks when we look at how HIV particles infect their preferred targets, our T helper cells. So now we're in the lymph node. We're looking at how HIV, brought to the lymph node by either one of our well-intentioned dendritic cells or maybe by a macrophage, manages to infect our T helper cells, aka our CD4 lymphocytes. Well, it all sort of comes down to receptors. On our T helper cell membranes, we have 2 to 3 receptors that help HIV gain access to these cells. We have the CD4 receptor, which is sort of the primary receptor that HIV needs, and we have either one or both of CCR5 and CXCR4. CXCR4 being much less prevalent. CCR5 is really the preferred co-receptor that most strains of HIV need to bind. But these are both called co-receptors in this context here. So what's important about these particular receptors is that HIV happens to have a protein, this thing here called GP120, on its envelope, the outer part of the virus here, that interacts really well with these receptors. You can almost think of it as a lock and key setup. These receptors here are some of the locks that need to be opened to gain access to our T helper cell, and unfortunately for us, HIV has the key, this GP120 protein on its surface. So how does it work? Well, GP120 on the HIV envelope, it first binds the CD4 receptor on a T helper cell. This binding between the two sort of induces a conformational change in the CD4 receptor protein here, and it allows our co-receptor here, either CCR5 or CXCR4, to grab a hold of this complex and pull the viral membrane and the T cell membrane closer together. And when they get close enough, this little stalk here, the stalk of the GP120 protein, it sort of pierces through our T cell membrane, and it pulls the viral and the T cell membranes even closer together. And what ultimately happens is that the two membranes will fuse together, which allows the HIV particle to essentially inject. Now that it has access to the inside of our T cell here, it injects its genetic material into our T cell, inside this viral capsid here. And that's in the form of viral RNA, ribonucleic acid. And this envelope is just sort of left at the surface of our T cell here. So once this capsid with viral RNA and some viral enzymes enters our cell, it gets degraded by some of our cellular enzymes. And this is essentially another bad move on our cell's part because it releases the viral enzymes and the viral RNA, which can now get to work on taking over our T cell. We kind of just got Trojan horsed in a way. And most viruses at this point are happy to just use our cellular machinery like our ribosomes and our cytoplasmic nucleotides to make copies of themselves, and they leave our DNA alone. But not HIV. HIV is a little sneakier than normal viruses, and probably the key viral enzyme among all of these that allows it to be so sneaky is this reverse transcriptase enzyme. So what reverse transcriptase does is it takes this viral RNA here, the one that came with, and it uses some of our nucleotides that are floating around in the cytoplasm to revert this viral RNA into a single strand of DNA. It uses the viral RNA as a template to synthesize a strand of DNA. And then it synthesizes a complementary strand of DNA for the single strand. So we end up with some double-stranded viral DNA here. And so right now, alarm bells are probably rightfully ringing in your head, right? We just went from single-stranded RNA to single-stranded DNA to double-stranded DNA. That's not supposed to happen. Remember the central dogma from your biology classes that said we go from DNA to RNA to proteins? And here we are doing the exact opposite of that? Well, that's exactly what's happening. We are doing the opposite, and that's why HIV is called a retrovirus. It subverts the central dogma, and it generates viral DNA from viral RNA. Outrageous. The other sneaky thing about reverse transcriptase I wanted to mention is that it makes a lot of errors doing all this polymerization, all this synthesis. It doesn't quite have the proofreading ability that our DNA polymerase enzymes have, that obviously come in handy when we're replicating our DNA. So on a practical level, what this means is that, well, A, lots of viral polymerase errors equals lots of mutations in the viral DNA. And that means that over time, the virus can develop resistance to certain antiviral medications because the medication eventually might not be able to even recognize the viral DNA. And B, it's really hard to make a vaccine against HIV because even small changes in the genes of the virus might render the vaccine ineffective. Remember, we're talking about one cell here and the mutations that happen within one cell, but keep in mind that there's potentially going to be millions of HIV-infected T cells in which HIV will be mutating ever so often. And actually, this reverse transcriptase enzyme is one of the targets for some of the medication we use to control HIV levels. We try to block this viral reverse transcriptase enzyme from working. Anyways, back to our now double-stranded DNA here. Another viral enzyme called integrase will come along and grab hold of it. It'll then bring it to the T cell's nucleus and carry it through one of our nuclear pores into the nucleus. From there, and this is sort of the point of no return in an HIV infection, the integrase enzyme nicks. It makes a little cut in our human T-cell DNA, and it allows this double-stranded HIV DNA to integrate itself into our DNA. And this step essentially establishes the lifelong infection with HIV. The viral DNA has sort of now become congruent with our own DNA. So from here, a few different paths can be taken. Well, either this DNA just sits here and isn't actively transcribed into mRNA, and we call this a latent HIV infection, when your cell has integrated viral DNA into your own, but is not actively doing anything with that DNA. Or your DNA transcription enzymes might come along. This is usually the more likely thing that happens. So let's say RNA polymerases come along. Well, it's going to transcribe this viral DNA here just as if it was your own DNA. So it'll start cranking out viral mRNA transcripts, which then leave the nucleus. They find some ribosomes, say on the rough endoplasmic reticulum, and they start to use the ribosomes to make proteins, like new envelope proteins, for example. These envelope proteins will then make their way through our endoplasmic reticulum, head up toward the cell surface, right, our cell membrane, and once enough get up there, they start to coalesce a bit, they cluster together. And this is actually happening in a lot of other places on our cell membrane. So you can see all the new GP120 proteins here on the surface of these viral envelope segments. And while this is happening, another key viral protein is being made at the same time. Actually, it's a viral polyprotein. Poly because it's essentially multiple different viral proteins laid out end-to-end on one long protein strand. So these will include those viral enzymes we talked about earlier, right? Reverse transcriptase, integrase, as well as some other proteins that the virus needs to be infectious. So all of these long viral polyproteins, along with some viral RNA, they also get brought up to the surface, to the areas where all the envelope proteins have clustered together. And so now, all of these components can come together to start forming a new immature HIV particle. And I say immature because it's not quite ready to infect other cells yet. One more thing has to happen before it matures and it's ready to be infectious. It needs help from yet another viral enzyme called a protease. Proteases are special enzymes that cleave up polyproteins just like this one here into smaller proteins. But they only cut at specifically marked sites. And this protease here, it does just that with this long viral polyprotein that's been made using our ribosomes. So it snips it at a few different sites, and we end up with what are all the components that an HIV particle needs to infect. So, for example, this might be its reverse transcriptase here, and this might be its integrase here, and so on. So the protease starts cutting things up, and while it's doing its slicing and dicing, these components here together, they all start to bud off the T cell as a new virion. And shortly after it buds off, the protease is finished cleaving this long protein up. So this is now a fully mature HIV particle. Now that it's used this T cell to be made, it's ready to go on and infect other cells, particularly, of course, T helper cells. But what happens with this T helper cell that was infected? Well, our old understanding of it was just that as tons and tons and tons of new virions budded off of our infected T cell, all of that budding off would actually kill our T cell. But recently it's been discovered that things are a lot more complicated than that. In the vast majority of cases, the T helper cell does die, but it's not because of the budding off of the virions. It's most often because infection and subsequent production of HIV particles, it sort of triggers this sort of self-destruct mechanism within the T cell. But I'll cover that in more detail when we talk about how HIV kills our T cells. So how do you diagnose HIV? I mean, normally when you're feeling sick, you can just kind of go to the doctor and tell them your symptoms, and they might just be able to diagnose you on the spot. But diagnosing HIV isn't quite that simple, and the reason why is because its symptoms are really non-specific. So, in other words, they're pretty general symptoms. So you might just feel like you have a really bad flu. You might have, a headache, or maybe some muscle pains or joint pains, or you might have a sore throat. I'm sure every one of us has felt that way in the past. But that doesn't mean we have HIV infections. So since we can't diagnose HIV on symptoms, then how do we do it? How do we make a diagnosis? Well, we do blood tests. So we look for a few different compounds within the blood. So we can look for antibodies that we've made against the HIV virus, or we can look for bits of the virus itself, maybe some of its enzymes or its proteins or some RNA. So after an HIV infection happens, actually let me draw a graph here to help explain. This might be useful. So here's our x-axis, and we'll put days down here, and we'll say day 0 is when we got our infection, right? And we'll go to a few months here, and then a few years down here. So after exposure to the virus, our immune system's going to kick in, right? It's going to kick in and start to make antibodies. And it takes about a month or so for most people to start making antibodies. And looking for these antibodies, right, testing for the presence of these antibodies is the most common way we diagnose HIV. So look here, you see the antibody levels start to rise about a month after infection. And then they drop a little, partially because, remember, HIV disrupts our immune systems, right? So they get in the way of how we make our antibodies. But then the numbers start to come back up a bit. So we're starting to get a handle on the virus. So for the time being, more immune cells can remain alive to be making antibodies. And back in the day, a few decades ago, our technology wasn't as good as it is now. And someone would have had to have been infected for almost 2 months before we could start to detect antibodies in their bloodstream. So back then, someone might have come in to get tested for HIV before this 2-month period, and they might be told that they didn't have HIV when in fact they did. So during this 2-month window period, there's a risk of getting a false negative result. A negative result despite truly having an infection. And this is problematic for 2 reasons. I mean, obviously we don't want to get the diagnosis wrong, but also people in this stage are the most infectious, right at the beginning when the infection is just sort of established. But luckily these days we've got better lab technology, better antibody tests that let us pick up on these HIV antibodies a lot sooner. So now instead of 2 months, we can detect antibodies almost as soon as they start being produced. So let's say, for example, it's like a month in, just like on this graph, although it can take longer to produce antibodies. But let's say it's about a month. That'd be about average. So we can detect them earlier, not because we're making antibodies any faster these days. We're just better at detecting their presence within our bloodstream now with our tests. So you see our window period that you might get a false negative in now has also decreased. So that's good. So those are antibodies. That's a way of diagnosing an HIV infection by looking for stuff our immune system has produced, right? But there's actually this other test that's often done at the same time as these antibody tests. And this test is one that looks for an HIV-specific protein called P24. So there's this protein inside the virus called P24, and you can see its concentrations do rise and fall fairly quickly here. Right now I'm drawing out the blood levels that we typically see of P24. So testing for it actually presents an interesting issue, because on one hand, it's great that we can potentially detect it even earlier in an infection than we can detect antibodies, right? So the window period is smaller, about 2 weeks now. But on the other hand, you kind of have to get tested really early on to detect it, or you'll miss it. And that's tough to do when you don't really have many symptoms. And by the way, the reason the concentration falls off here is because once our antibodies start to develop, right, you can see them sort of going up here, they bind to the P24 antigen and form these little complexes which aren't really detectable using our standard P24 antigen test. So let's say, for argument's sake, that you do test positive on either the antibody or the P24 test, or both. What happens then? Does that mean you definitely have HIV? Well, there's a system of double checking just to make sure. So these antibody tests are done by a process called ELISA, enzyme-linked immunosorbent assay. And that's a huge mouthful of words, but essentially all that means is it's a lab test that mixes our blood sample with some enzymes and some other antibodies that actually detect, they stick to HIV antibodies or to the P24 protein. So let me give you some scenarios here. So let's say you test negative for these things. Well, in that case, you can be fairly certain you don't have HIV, and based on your risk factors for HIV infection, you can just get tested again in another 3 to 6 months or so if you feel you're at high risk. But if you get a positive ELISA test, we want to just double check that result, right, just to be sure that it's the HIV virus that's actually causing the positive result. Because believe it or not, certain conditions like lupus, you may have heard of lupus, or diseases like syphilis can cause this test to be positive. So to really specifically test your blood for HIV, your blood will then move on to a second test, a Western blot. And this Western blot test specifically tests your blood for actual viral proteins. So let's say this is our Western blot testing strip here. We're essentially looking for the presence of some of the proteins that are on the viral envelope. So maybe some GP120 or some GP41 and so on. And we also look for specific proteins that HIV makes. So, for example, some of its enzymes like its reverse transcriptase or its integrase. So the Western blot test is just a double check that can detect for actual viral proteins to make sure it's HIV and not something else that's giving you a positive ELISA test result. And so bringing it back to overall diagnosis. So if you have a positive ELISA and a positive Western blot, then a diagnosis of HIV is confirmed. There's a 99.99% chance that you do have an HIV infection. But if your ELISA was positive and your Western blot was negative, then the ELISA, at least for HIV, was a false positive. So there's a super high likelihood that you don't have HIV. Remember, there's some other things that can make the ELISA report positive when it actually isn't. But for the most part, it's still about 99.5% accurate for HIV. And of course, if your ELISA was negative, then again, really, really unlikely that you have HIV. Unless, of course, you were in the window period when you got tested, in which case it'd be pretty important to get tested again after about 3 months or so, when your antibodies would have time to have developed. So the last thing I want to mention is that it's important to know what subtype of HIV you're dealing with. So we've got 2 slightly different types of HIV virus. We've got HIV-1 and HIV-2, with number 1 being the most common by a long shot. And they're both pretty similar to each other. They cause the same illness. They just have a few different proteins and a few different enzymes here and there. And, the main reason you'd want to know what type you're dealing with is because some of the standard drugs we use to treat HIV-1 don't work very well for HIV-2. So we want to know which one we're dealing with. So we look for their RNA. And that's great because not only can it tell us whether we're dealing with HIV-1 or 2, but it also becomes detectable really early on in an infection, from about day 12. So now our window period potentially can be really small. And so we look for this RNA via nucleic acid testing, NAT, which is not the same as the ELISA or the Western blot that we saw before. This is a special kind of test that can find tiny amounts of HIV nucleic acid in our blood sample. And then when it finds them, it amplifies them. It makes lots of copies of them so we can detect that they're there. So the last thing I'll mention is that there's something called rapid HIV testing, and that's becoming more and more available in more and more places, and that makes testing quicker and easier to do, so more people can get tested. And they're pretty simple. They're not a give a full vial of blood sort of test. All you have to do is just get a swab inside the mouth or a finger prick test just to get a little bit of blood. And the other awesome thing about them is that you can get your results in only about 20 minutes, whereas the tests I mentioned before all take a few days to a week to get your results. So these rapid HIV tests, they work by the same ELISA method I talked about earlier. They check for the presence of HIV antibodies and P24 protein, which you can detect in your saliva and, of course, in your blood. So the slight issue with rapid tests is that even though they're quick and they're easy and they're cheap, their accuracy is a little bit less than the conventional tests we talked about earlier. So they're more of a screening test than a diagnostic test. In other words, they're really, really good at detecting true negatives, so if it comes up negative, it's highly likely that you do not have an HIV infection. But if they come up reactive or positive, then you'd have to go through the conventional diagnostic tests to confirm or deny these results, right, just to make sure. You may have heard the term HAART referring to HIV treatment, but what exactly does that mean? Well, HAART, which stands for Highly Active Antiretroviral Treatment, refers to the sort of modern-day present treatment regimen for treating HIV infections. And it's called highly active because compared to the previous treatment regimen, HAART is just a lot more effective. And so the name just kind of stuck. So before we'd give just one type of drug to help control an HIV infection, we'd usually give an NRTI, which stops the reverse transcriptase step in infection of a CD4 cell. But, HIV likes to mutate a lot, and it turned out that when only one type of drug was given for an infection, the HIV would eventually become resistant to that type of drug. So, of course, the drug didn't work anymore, and the person's infection would almost sort of pick up where it left off. It would start to worsen again. Except this time almost more aggressively in a way, because now it'd be resistant to that original type of treatment. But in comes HAART, highly active treatment. And, it's not that we're using totally different drugs. I mean, sure, we've got a few more types at our disposal now, but the key thing is that nowadays we know that if we give 2 or 3 drugs, which is what we usually do in HAART, so if we give 2 or 3 drugs instead of just one, the HIV infection can be really well controlled. And what do I mean by that? Well, each of the drugs in a particular HAART regimen works in a slightly different way, stopping HIV at different points during its replication. So these drugs used together are really effective at preventing HIV from making copies of itself. Its life cycle just won't be able to continue, so new virions just don't end up being made. And if we do encounter, by chance, an HIV particle that's resistant to one of the antiretroviral drugs, chances are it wouldn't be resistant to the other 2 drugs that make up that particular HAART cocktail. And, it'd be really hard for HIV to become resistant to all of the drugs in a particular HAART regimen. I mean, here, let's do some math. Not super hard math, I'll leave that to Sal, but in your body, HIV multiplies essentially, and it creates a few billion new viral particles per day. And during replication, its reverse transcriptase enzyme makes a lot of mistakes. In fact, for every about 10,000 nucleotides it adds on to a new strand of DNA, it makes a mistake and it inserts the wrong base. 1 in every 10,000 bases is wrong. And it doesn't have a very good repair mechanism like we do for our DNA, so this mistake sticks around. So let's say, for argument's sake, that one of these mistakes affects one of our drug's target proteins within the HIV. Let's say this stretch of DNA here was supposed to code for integrase. So this virus's integrase enzyme will still work, but our integrase inhibitors might not be able to stop it anymore because it's mutated. Well, our HAART cocktail would still be able to stop this mutant HIV because we have other places in the replication cycle that we can inhibit it. So essentially, a virus would have to mutate, either randomly or sort of evolve by selective pressure, to become resistant to all of the heart drugs that we're throwing at it in a given cocktail. And in fact, the chance that it could become resistant to all three of the types of drugs would be at the very least 1 in 10 to the 12th power. That's 1 in a trillion chance. I'm just multiplying 1 in 10,000 here by 1 in 10,000 here by 1 in 10,000 here. And, I'm being really generous here because this is assuming that the 1 in 10,000 base mutations are even occurring at the target enzyme's coding sequence of DNA. So bottom line here is that it'd be extremely unlikely for an HIV particle to mutate during replication in a way that would let it escape from all three of the heart drugs. And, of course, it would be extremely unlikely to thus find an HIV particle just floating around in the bloodstream that's resistant to multiple drugs. Because remember, replication is actually suppressed by taking the ARVs. So once you're on heart, potential mutants aren't even being created anymore. Or at least a lot less so. So now you have an idea of what heart is. A drug cocktail. 2 to 3 different types of drugs all taken together that A, makes drug resistance by HIV really unlikely, and B, that's still able to fight off resistant strains that we might encounter. But there's a few other things to consider with heart. For example, who gets heart? And when is it prescribed during the course of the infection? And how do you sort of take it? Is it a bunch of pills? Is it an injection? Well, let's start here with who and when, because you might reasonably think that, everyone who's diagnosed with HIV gets started on heart right away, and there's good evidence that that is a good idea. But it gets a little complex because there are some drawbacks to starting therapy early, and by early I just mean before the onset of any symptoms or AIDS-defining illnesses, and, these drawbacks need to be considered. For example, there are some side effects of the ARV drugs, such as an increased risk of cardiovascular diseases like heart attacks or strokes. There's potential problems with bone health, too. Long-term exposure to these ARVs are associated with a greater loss of bone density as a person gets older, more than the normal loss that happens as you age. There can be psychiatric side effects, too, like feeling a bit sort of sluggish in your thinking. And there can be gastrointestinal side effects too, like chronic diarrhea. So you can imagine that if someone has HIV, but they're in the latent phase, in other words, they're not having any symptoms, starting them on antiretrovirals might actually cause a decrease in their quality of life at that given time period. The other thing that needs consideration is that, if you do start a heart treatment regimen, then you need to stick to it for the rest of your life, taking your medication every single day without fail. Because studies have repeatedly shown that stopping your ARVs, or not taking them every single day as prescribed, is associated with the HIV in your body becoming drug resistant. So that means that in the future, if you decide to start your treatment again, your drugs just may not work as well anymore. They may not work at all anymore. So when you talk to your doctor about the right time to start your treatment, you'll probably go over some strategies to make sure you can take your medication every single day to minimize drug resistance from happening in your infection. And one thing that's helped out in a huge way for people taking their medication every day is the fact that these combinations of these drugs, remember you're taking cocktails of usually 3 of these types, combinations are available in a single daily pill nowadays, and that makes it a lot easier to stick to your treatment schedule. A few years ago, and actually still in some countries, you'd have to take a handful of pills every single day, sometimes multiple times a day. And now you can get your whole combo in one single pill, taken once a day, so that's really, really useful. So now we know there's potential problems with starting heart too early. But, when is the right time to start then? Well, it is a little different for each person, so you'll have to have a chat with your doctor about the right time to start. But there's a few general principles that'll help guide the decision that you guys come to. So for one, we know that if your CD4 T cell count is less than about 350 to 500 cells per cubic millimeter of blood, then it's time to start heart. Remember, CD4 count is sort of used as a marker for how far along the illness is, right? The lower the CD4 count, the more damaged the immune system is. Viral load is important too. If the amount of HIV in your bloodstream is higher than 100,000 copies per milliliter of blood, it's time to start heart. And, I guess the last thing I'll say about this is if a person is pregnant, if they're a young child, if they've progressed to AIDS, or if there's an opportunistic infection or an AIDS-defining illness present, then regardless of CD4 count, even if you're higher than that 350 to 500 cutoff, heart needs to be started right away to help your immune system recover as much as possible. But let's talk about the antiretroviral medication. So there's about six main types that we use to prevent HIV from working properly. And they all kind of work in slightly different ways. They all have their own sort of flair. So a typical treatment regimen, right, that involves taking at least 2 of these, but preferably 3 of these different types of medications at the same time. And, we don't just do that arbitrarily. The reason we do this is because it's been found that taking just one kind of drug gives the virus the opportunity, the chance to become resistant to that drug. And, that's obviously not very good, but it turns out that giving a few different kinds, right, 2 or 3 all at once, makes it really, really tough for HIV to get resistant to any of them, because essentially the HIV dies before it has a chance to mutate and become resistant. So because of this, before you're actually started on any of these antiretrovirals, you'll probably have some testing done to see maybe which types of medications you're already resistant to. So let's work on our list now. So 2 drugs that we can have as part of our treatment. They start right at the very beginning here. So we've got fusion inhibitors, right? And they bind to this GP120 protein, or the GP41 of the virus. And they prevent HIV from binding to and entering our CD4 cells. So they work by sticking to certain proteins that HIV kind of needs to enter our cell. And they stop this fusion step from happening. And we also have CCR5 antagonists, which bind to the CCR5 protein here that sits beside this CD4 protein. So remember, in most cases, this CCR5 is also necessary for HIV entry. So now, all of a sudden, this HIV is going to have a really, really hard time entering our cells. It's kind of like gumming up a lock on, say, your car door or something like that. So you just can't really get the key in anymore, and you're kind of locked out. And, you got tons of CCR5 proteins all over your CD4 cell, and there's obviously tons of GP41 proteins on HIV particles, but the idea is that you take the right dose of the drug so that you end up with enough little bits to gum up the majority of these proteins. So let's actually keep our list up here up to date. So fusion inhibitors are a type, and CCR5 antagonists, they're another type of antiretroviral. But, let's say some HIV does get through it, does fuse, or maybe you're just not on one of these fusion inhibitors. Where's the next place in this sort of pathway that we can block off HIV? Well, remember, this step here is reverse transcriptase, that enzyme, jumping onto the viral RNA once it gets into our cell, and then it starts to make single-stranded DNA out of it, right? Well, we actually have another 2 types of drugs that work at this stage. So one is called a nucleoside reverse transcriptase inhibitor, an NRTI. So just think about what's happening here, right? So reverse transcriptase is using viral RNA, right? This really nice cobalty blue strand as a template to create viral single-stranded DNA, right? This lighter blue one. So to actually put together this new single-stranded viral DNA, reverse transcriptase has to kind of fish around in the area and grab onto some of our nucleosides that are floating around, and then it attaches them together, right, like end to end, to build a strand of DNA. Remember, nucleotides and nucleosides are the building blocks for our DNA. So what we've come up with, right, what this NRTI does is it's essentially a decoy nucleoside. So it looks just like one of our normal nucleosides, but geniusly, it's missing a key component, which makes it impossible for HIV's reverse transcriptase to attach another nucleoside to its end. And if it can't do that, then this DNA just can't be built, right? It stops being created because it can't be elongated anymore, right? The next piece can't sort of be tagged on, attached on. So those are NRTIs, but, another way this reverse transcriptase step can be interfered with is just by gumming up the reverse transcriptase enzyme itself. Think about how Spider-Man catches Doc Ock or the Hobgoblin. He kind of gums them up with his web blaster. And, it's a similar thing that goes on here, obviously, unfortunately, minus Spider-Man. So these drugs that gum up reverse transcriptase are called non-nucleoside reverse transcriptase inhibitors, NNRTIs. because they do inhibit reverse transcriptase, just not by anything to do with nucleosides. They actually work on the enzyme itself. But let's say that HIV mutates, again, as it often does, and then these drugs just don't work anymore. What's the next sort of step? What's the next stage we can interfere with it at? Well, remember here, right, this viral integrase enzyme, it kind of grabs a hold of this double-stranded viral DNA here, and then it tries to bring it into the nucleus to integrate it into our DNA. Well, we have integrase inhibitors that stop this little viral enzyme here from doing what it wants to do. So our drug essentially grabs onto the integrase and just hangs on really, really tight. So then integrase can't bring any viral DNA into our nucleus, right? Which means ultimately it doesn't end up integrating the viral DNA into our DNA. And you know, this step is really, really good. This is an extra important step here because it's been shown that viral DNA integrating into our DNA is a major, major trigger for our cell to undergo apoptosis or self-destruction. So, you know, just as a general rule, the less viral DNA that actually does this integration step, the fewer CD4 cells that we end up losing. So now let's add that to our list, right? Integrase inhibitors. Now, let's say you're not taking an integrase inhibitor. What's the next and sort of last step we'll talk about where you can interfere with HIV? Well, remember that after integration, our RNA polymerase is going to come along, right? And it's going to transcribe this bit of DNA here, including the viral DNA, unfortunately, and turn it into viral RNA and viral mRNA. And then this mRNA is going to sort of hop into a ribosome and get translated into a viral polyprotein. And that'll get cleaved up by viral protease so that a really, infectious working viral particle gets produced, right? Well, not if we can help it. So our last drug that we'll talk about is called a protease inhibitor. And, there's actually a few different kinds of these too, but the one I'll mention actually binds to the active site, right? The site that does all the work on this protease enzyme here, the sort of Pac-Man mouth part. And again, it sort of gums it up. It stops it from working so it can't then go on to cleave up this viral polyprotein. So that's good, that's great. Now this little baby virion here won't go on to get mature or become infectious. So you can see that by using some of these drugs, right, in combination, we can really, really minimize how much HIV can replicate within our bodies, right? Because we can stop it from getting into our CD4 cells, which it kind of needs to replicate. And as you saw, we can stop it at a few other places as well. So ultimately, you just end up with a way lower viral load in your bloodstream. So we know a little bit about HIV now. It's a virus that attacks your immune system, and if untreated, it will cause a state of immune failure, immune deficiency in a person. And that immune deficiency state is referred to as AIDS. It's essentially late stage of an untreated HIV infection. So I just want to talk a little bit about some of the ways that HIV is transmitted, some of the different ways you can possibly get HIV into your bloodstream and thus develop an HIV infection. And let's actually do this in a bit of a simplistic way, because it turns out that HIV is most often transmitted through contact with 3 different types, I guess, of body fluid from an HIV-infected person. So contact with their blood, with their sexual or genital fluid, and I'll expand on what that means in a minute or so, and from breast milk contact. And let's actually look at this in terms of 4 fairly common scenarios. These will be the most common situations that HIV is spread via these groups of fluid here. And let me just make it clear that these infected body fluids would need to come into contact with broken skin or directly with your bloodstream, maybe via an injection or something like that. Or they'd have to come into contact with one of your mucous membranes, which are just parts of your body that aren't protected by normal skin. So, for example, inside your mouth or inside the vagina or the rectum or at the opening of the penis, HIV can cross into your body through these mucous membranes. You won't just become infected by, say, just looking at these fluids or just being near them or anything like that. One of these fluids would have to make it inside your bloodstream or make it through one of your mucous membranes by physical contact for you to possibly develop an infection, okay? So top left up here, we'll make this sexual fluid contact, which is actually the most common way that HIV is spread, typically when having unprotected sexual intercourse with someone who has HIV. And don't let these pictures scare you. These are just cross-sections of pelvises. So a female pelvis on the left here and a male pelvis on the right here. So we can use these to look at the sexual organs. So contact with sexual fluids like semen or preseminal fluid or vaginal fluid or even rectal fluid can spread HIV because there's often a fairly high amount of viral particles within these fluids, particularly within the first few weeks of a new HIV infection, when the infected person's viral load in their blood or in their sexual fluids is up at extremely high levels. But in terms of actual sexual activities, in general, unprotected anal sex with either a man or a woman is the highest risk sexual behavior, because not only is there exposure of HIV-infected sexual fluids to mucous membranes, right? The opening at the tip of the penis and the inside of the rectum in a woman or a man are mucous membranes. But if there's any trauma to the involved body parts, there can be some blood there as well, and that might have virus in it and thus increase the risk of infection. Virus from infected sexual fluid or blood can get across the mucous membranes of an uninfected person, or it can just get directly into a person's bloodstream through an area that might be bleeding. Now, this is not to say that unprotected vaginal sex is not risky as well. It turns out that unprotected vaginal sex is the second highest risk sexual behavior. Because again, there's exposure of sexual fluids, right, semen and vaginal fluid, to mucous membranes, which HIV loves to hop across when it can. And again, there could be, although less likely than in anal sex, there could be trauma to the involved body parts. So there can be some blood involved as well, of course, containing the HIV. And just so that I'm perfectly clear here, anal sex, I said, had the highest risk of transmission, and vaginal sex the second highest risk. But vaginal sex is the way HIV is transmitted most frequently overall, because overall, more people have vaginal sex over anal sex. And so last in this sexual-themed quadrant, I just want to mention that oral sex of any kind, so using the mouth to stimulate the penis, the vagina, or the anus, carries a risk of transmitting HIV for much the same reasons as before. Mucous membranes of the mouth being exposed to sexual fluids, and mucous membranes of the penis or the vagina or the anus being exposed to possibly blood. Maybe the person's mouth has some open sores in it, which happens to be one of the symptoms that can happen in an HIV infection. And on that note, actually, having untreated sexually transmitted infections like chlamydia or syphilis or herpes vastly increases your risk of transmitting or becoming infected with HIV in risky scenarios, because you're more likely to have breaks in your skin or your mucosal surfaces from symptoms of these STIs, like sores or ulcers. And through these, HIV can more easily infect you. All right, next quadrant here. So after sexual transmission, right, the most frequent mode of transmission, exposure to infected blood. So that's the next most frequent mode of transmission, and in particular, procedures involving needles contaminated by someone else's blood. So, for example, using intravenous drugs and then sharing needles with an HIV-infected person. In that case, HIV is just one of the many viruses you might pick up by sharing needles in IV drug use, because you're essentially transferring tiny droplets of an infected person's blood directly into your bloodstream on a needle. Other needle-related procedures, needle stick injury. Let's say you're a healthcare worker and you're working with an HIV-positive patient, right? Maybe you're drawing some blood or something like that. You might accidentally get stuck by the needle after it's been contaminated with their blood. And this does occasionally happen, unfortunately. There's a risk of HIV transmission from them to you there. And remember to keep in mind that risk of transmission depends on some extent to a person's viral load. So these risks are all sort of modified to be higher or lower depending on how much HIV is in a person's blood. Typically very low amounts of HIV if they're being treated with specific medications, and typically pretty high amounts of HIV if they're not being treated. The last thing I'll say here is contaminated blood transfusions, and this isn't so much of an issue these days, at least not in most countries, because of some seriously rigorous screening of donor blood and the blood supply that blood banks have on hand. But back in the olden days, before the sort of late 80s, early 90s, donated blood was not routinely tested for HIV, as crazy as that sounds. So contaminated transfusions don't happen very often these days in most countries, but worth a mention here because it's still something to be aware of. Now, Third quadrant, what's the third most frequent route of HIV transmission? Well, it's actually from an HIV-infected mom to her baby during childbirth. And kind of alarmingly, around 90% of the HIV that we see in kids, they actually got it in this way from their mom during their birth, which is also called vertical transmission, mom to child during gestation or during birth. And we're not 100% sure how the transmission happens, but the thought is just because they're being exposed to mom's blood and vaginal fluid on the way out of the birth canal. And because newborn babies are essentially all mucous membrane at birth. They just have really thin skin. So it's not too hard for HIV to jump on board, so to speak. Luckily, there's all sorts of medications that we can give to mom before and after her pregnancy and labor, and there's medication that the baby can take as well, and all of that drastically reduces the risk of mom passing HIV onto her baby from a risk of about 25 to 30% HIV transmission without medication, all the way down to only about 1-2% with medications. So around a 20-fold reduction in mom's chances of passing HIV onto her baby with the proper medication. Now, last quadrant, this one also involves mom and baby. It's transmission of HIV via breastfeeding. Breast milk in an infected mom will contain HIV particles, so when the baby feeds, it'll be ingesting lots and lots of HIV particles, which obviously mom is not intending. And it's not clear how the HIV gets into the breast milk in the first place, but when the baby ingests it, it can infect the baby by being absorbed through the digestive tract. So before we wrap up, I just want to briefly mention two things. So first, the risk of transmission in at least this quadrant here, it goes way down if the infected person is using condoms to sort of physically block HIV transfer, and also properly taking their HIV medication to reduce the viral load in their body, in their blood and the fluids that we mentioned in this scenario here. But also that second one, the properly taking the HIV medications, that will vastly reduce the risk of transmission in needle sharing and in mom to newborn transmission and in breast milk, all of these scenarios here. The second thing is that these are all ways you can contract an HIV infection, but I think it's worth mentioning a few ways you can't contract an HIV infection that might not be well known, or there might be some myths around these. So unless any of these has been contaminated by infected blood, HIV is not transmitted by body fluids like saliva, or tears, or sweat, or urine, or feces. And it is not spread through the air like, say, tuberculosis is. So being around people with HIV won't somehow transmit the virus through the air to cause an infection in another person. And it's not spread from casual contact either, say from shaking hands with or hugging someone who has HIV. It actually doesn't even survive very well outside a human body, so you can't become infected by sharing plates with an infected person at a restaurant or touching a toilet seat at a public restroom or anything like that. But there you go. The main routes of transmission: unprotected sexual activity, contaminated needles from mom to newborn, and via breast milk.